Good morning. I'll be presenting a lecture on types of anchorage in orthodontics. As we all know, whenever we want to do any orthodontic treatment, final outcome depends on the tissue reaction or biology of the soft tissues that is being involved, say periodontal ligament, and thorough understanding of biomechanical principle which an orthodontist employs during fixed orthodontic treatment. So the basic objective of anchorage planning is to maximize desirable tooth movement and to minimize undesirable effects. Depending on this, anchorage as defined by angle and case is resistance offered by units to unwanted tooth movement. These units may be a single tooth, group of teeth, or any other anatomical area of the head. Graeber defined anchorage as nature and degree of resistance to displacement offered by anatomic units when used for the purpose of effecting tooth movement. Profit, he defined anchorage as resistance to unwanted tooth movement. It is a resistance to reactionary forces created when the type of tooth movement is being carried out. Nanda, he defined anchorage as the movement of anterior and posterior teeth once we are doing extractions of premolars to achieve selected treatment goals. Coming on to classification of anchorage, Autophy, he classified anchorage as simple, stationary and reciprocal anchorage. Tweed classified anchorage as first degree, second degree and third degree anchorage preparation. Moyer classified anchorage according to manner of force application, that would be simple, stationary or reciprocal anchorage. According to jaw involved, it could be intramaxillary, intermaxillary. According to number of anchorage unit, it could be single or primary anchorage, compound anchorage, multiple or reinforced anchorage. According to site of anchorage, it could be intraoral or extraoral or muscular. Nanda, he classified anchorage as type A, B, C, where Ganley and Goldman called the same thing as maximum, moderate and minimum anchorage respectively. Recent advances include temporary anchorage devices, which we'll be dealing in the end of this lecture. Now, simple anchorage, it is a form of anchorage in which anchor teeth, they are not allowed to move, but if at all they move, they will tip. But as we all know, tipping needs minimum amount of air, so it is the weakest form of anchorage. It is obtained by engaging the appliance with greater number of teeth than those involved in the same dental arch. As you can see in this figure, the posterior segment is large, that is fitting against the smaller anterior segment, whereas expansion screw is placed for the labial movement of the incisors, like in class 2 dip 2 malocclusion. Stationary anchorage, here the anchor teeth are not permitted to tip, rather the displacement, if at all it occurs, it will be by bodily tooth movement. As I told you earlier, tipping requires 50 gram of force, where bodily movement requires 150 gram of force. So we are not going to apply such higher forces so that molars will move forward, because anterior teeth being smaller need lesser amount of forces to move back. It is the most advantageous and desirable form of anchorage. In Beck's technique, a combination of anchor bend and class 2 elastic pits the mandibular molar against the maxillary anterior segment. The resistance to bodily movement of mandibular molars help in retracting the maxillary anteriors by tipping them. Because of the anchor band, the molar will be tipped distally, so if at all it corrects, it will upright, and then if at all it moves forward, it will move bodily because of anchor band being placed. Now this is a simple anchorage where a single tooth is being fitted, stationary anchorage where we are making a loop or some sort of bend in the wire so that tooth, if at all it moves, it will move bodily. Now coming on to next, that is a reciprocal anchorage. It is a mutual resistance offered by two anatomical units against each other. This is an equalized, controlled and balanced tooth movement obtained by reciprocal actions between various teeth or group of teeth, like closure of midline diastema, arch expansion appliance, use of cross elastics, use of box elastics, use of class 2 or class 3 elastics. Now this is an example of reciprocal anchorage. You can see midline diastema. If finger spring is being used, it will tend to tip the incisors, rather root uprighting will not be seen. But if we are using any type of fixed orthodontic mechanics, the bodily movement of incisors will happen to close the midline diastema. Now, cross elastics being used for correction of crossbite. They are also an example of reciprocal anchorage. As you can see, maxillary premolar will move palatally, while mandibular will move buccally and will correct the buccal non-occlusion. Intramaxillary anchorage. This is a resistance. Our units are within the same arch, maxilla or mandibular arch. Whereas an intermaxillary anchorage, resistance unit will be between maxilla and mandible. So both the jaws will be involved, as we'll be seeing. Baker's anchorage is an example of intermaxillary anchorage, also termed as use of class 2 and class 3 elastics. You can see in this class 2 elastics used for class 2 malocclusion, The elastics are being worn from the mandibular molar to the canine for retraction of anterior teeth so that molar will not move forward. Whereas in this, you can see for class 3 elastics used for class 3 malocclusion, here elastics are being worn from the maxillary molar to the mandibular canine used for class 3 malocclusion. This is an example of Baker's anchorage. Now, Nanda's classification type A, B, and C anchorage. Type A anchorage where maximum amount of movement is happening of the anterior segment. Type B where moderate anchorage where symmetrical space closure is there, say 50% anterior, 50% posterior teeth will move to close the space. Type C, it is a non-critical posterior anchorage where 75% of space closure is achieved by mesial movement of the posterior teeth. You can see in this diagram in first figure, the premolar has been extracted. You can see in next figure, there is more than 75% movement of the anterior teeth and very negligible movement of the posterior teeth. That is group A anchorage. Group B, where the same amount of movement happens for both anterior and posterior segment, 50-50%, that is group B. In group C, there is a maximum movement of the posterior segment. Anteriors are not being are negligibly moving backward. So this is an example of group C or minimum anchorage. Now, anchorage according to number of units, it could be single or primary anchorage, where this anchorage is provided by a single tooth. The teeth with increased surface area and multi-rooted teeth are selected. Say molars, when pitting against a canine, which is a single tooth, will provide an anchorage. Compound anchorage, where more than one teeth are being added. Say we are adding second premolar or second molar to the anchorage unit, that is your first molar. So this will be compound anchorage, or in loops when we are giving alpha or beta bend, that is also providing compound anchorage. Reinforced anchorage, in which more than one resistance unit is utilized, it is known as reinforced anchorage, like use of headgears, use of transpalatal arch, which is a bar which is being connected between molars of right and left side. So whole arch is fitted against two molars that are being joined by a rigid stainless steel wire. The muscular anchorage, normal tonus of perioral musculature can be utilized to provide an anchorage. Like lip bumper, it does not allow mandibular molars to move forward, and if activated, it can move the molar distally. The same appliance when used in upper arch is called Danforth's appliance. You can see in this a U-loop is being made. Because of this U-loop, the molar will not move forward, but whenever the lower lip exerts pressure on the acrylic pad, there will be rather some amount of distal movement of the molar. So lip bumper can be used for space regaining, for molar distalization, for providing anchorage, for correcting habit of lip trap. The Tweed's classification, he classified anchorage as first degree anchorage preparation, which is applicable to all malocclusion with ENP ranging between 0 to 4 degree, in which facial aesthetics are good and total discrepancies does not exceed 10 millimeter. Here terminal molar must always be uprighted, so direction of pull of intermaxillary force during function will not exceed 90 degree when related to long axis of these teeth. Second degree anchorage preparation A and B more than 4.5 degree in facial aesthetics make it desirable to move point B anteriorly, point A posteriorly. Here mandibular molars must be tipped distally. Direction of pull of class 2 elastic should be greater than 90 degree during function so that terminal molar will be further depressed rather than elongated. Now, third degree anchorage preparation, whenever the discrepancies are more than 14 to 20 millimeter more, but A and B angle do exceed 5 degrees. So, in this, what we have to do, the distal molar that is being tipped near the level of the marginal ridge, below the level, cervical to the marginal ridge is below to the cervical gingival margin. It is severely distally tipped. Now, extraoral anchorage, here the anchorage from resistance unit is situated outside the oral cavity. It could be cranium, occiput, back of the neck and the face. It is used to reinforce anchorage. Disadvantage, lack of patient compliance, poor aesthetics. It is being provided with the help of headgears which can move the molar distally and as well as it can provide anchorage. Now you can see these are the type of anchorage. This is a reverse pull headgear, first one, which is being used for correcting class 3 malocclusion. Here the support is taken from the nape of the neck, which acts like an anchor unit. This is a cervical pull headgear used for horizontal growers. This is a high pull headgear where support is taken from the occipital and the parietal region, that is used for vertical growers. This is an intermediate headgear where the support is, or a combined pull headgear where support is taken both from the parietal and the cervical portion of the neck. So, uses of extraoral anchorage to provide additional support for intraoral anchorage. prevent increased procubency of mandibular incisor teeth, preventing posterior teeth from shifting forward, to move the entire arch distally, reinforcement of anchorage, retraction of anterior teeth. Headgears can be named according to the point of attachment, which I've just told you. Cervical pull headgear, like say from nape of neck, occipital headgear, high pull headgear from the occipital region. Mode of attachment of headgear. Headgear elastic steps or J hooks are used on the outer bow. Inner bow is inserted in the molar tube by the patient for desired function. This is a safety release step which is attached to safety release is attached to the head cap or the neck cap, and the force is being exerted by putting the outer bow into the hole, respective holes. Then that force has to be checked by corex. So normally when we are planning an anchorage, 150 to 200 gram of force is sufficient. Now coming on to use of temporary anchorage devices, these are the rigid osseous fixation in form of mini screws or mini plates that defines anchorage in a new perspective. Because still now the rigid anchorage or a 100% anchorage was only provided by headgear, which needed a patient compliance. And so it is now being not being used routinely. Rather, we place temporary anchorage devices in such patients. Why implants? Because the conventional methods are less than ideal, as they take anchorage from structures like teeth, which itself are mobile, and they heavily rely on patient's compliance. Temporary anchorage devices, because they are in the patient's mouth for time being, and after that they have to be removed once the orthodontic treatment is over. So they should be small, affordable, easy to place, able to resist orthodontic phases. You can easily load them, easily remove them, and can be used with common orthodontic mechanics. When to use TAD, like say there is a premature loss of permanent molars, for retraction in maxillary maximum anchorage situations, in severe vertical problems for intrusion of molars or incisors, we can use TAD. It could be used as an implant in the palate. It could be used as implant mini screw or mini place placed between the teeth or in the zygomatic arch region, depending on the case requirement. So basically they are endo-osseous implant, and there is no need for osseous integration for these implants as needed for prosthodontic implants. So these are the common sites, say in the retromolar area where we are distalizing the full arch. Now during retraction of anterior teeth, a common site is placement between 5 and 6, as you can see in the figure. Okay, for molar intrusion, you can place the implants diagonally opposite, one on the buccal, one on the palatal, and then you can take a e-chain, you can attach to the attachments on the band, or you can take it across the occlusal surface. This will provide good amount of molar intrusion. Now while placing, we take a help of the jig. So with the jig, what we can do, we can know the area between the roots where we have to place it, take an X-ray, and through the same jig we can place the implant by drilling a pilot hole, inserting a mini screw, and that could be loaded immediately.